Good morning, and thank you all for attending, and very sincere thank you to Michelle and Mark for inviting me and giving me this opportunity to present some of the data that we have from MGH and some of the national data that hopefully will be interesting and helpful to the group. So we don't have any disclosures. And so what we've learned from resectable disease is that we want an R0 resection, and Scott has just beautifully presented a lot of the data that we know, and that we know from the ACCORD trial that we finally have some regimens that actually are effective in pancreatic cancer. And that really has changed the landscape and has made this such an exciting time for pancreatic cancer, because we don't only have gemabraxane, but we also have FOLFIRINOX. And it's been a long time since we've had regimens that have been truly effective for pancreatic cancer. And so really the question was, can we apply what we've learned in resectable disease and what we know from the metastatic setting, and can we put this onto the subset of patients who are borderline resectable or locally advanced? And so then I'll present some of the retrospective data that we have, and then I'll show you some of the data from some of the clinical trials that we've run that I think will be interesting, hopefully, to the group. And so when FOLFIRINOX first came out, we started to say, well, if in the metastatic setting it works, and in the nihilists all say that pancreatic cancer, everybody's metastatic, right? That's the true nihilist when looking at the disease. And we set up two clinical trials, one for borderline resectable patients and one for locally advanced patients. And this is the true anatomic definition, not the physiologic definition, because we all know from the international consensus guidelines that many of the people here in the audience participated in was that it's not only the anatomic, but it's also what the patient looks like. But this is the true anatomic definition of the disease. And the patients were either put into the locally advanced trial or the borderline resectable trial. All patients got 8 cycles of FOLFIRINOX. Depending on the anatomy, they got 50.4 gray of radiation and then a 6-week break prior to the operation. For the patients who were borderline resectable, where there was not very much venous involvement, they did sometimes get randomized to protons. And so we had run 2 phase 2 studies for proton beam therapy, which is 5 times 5 gray, very similar to sort of SBRT radiation treatment, but I will tell you, with protons, the patients tolerated it incredibly well. But what we did learn is that you cannot wait 6 weeks to operate on somebody if you give them protons or SBRT. If you give them 5 times 5 gray, you're much better off going to the operating room 2 weeks later. Now, you may not have the full effect of radiation from a downstaging standpoint, but we all know that the effects of radiation do continue on. But if you do it within 2 weeks, the operation is considerably easier than when you do the operation 6 weeks later, just in terms of the fibrosis and in terms of the blood loss and vascular injuries that we had. And so I'm going to just show you some of the data here and I'll show you the results of this, which was published in JAMA Oncology just a few months ago. But it was a borderline resectable, so we had 48 patients enrolled, 9 dropped out, 39 ended up going to the operating room, and 31 out of 32 who were resected had an R0 resection rate. When you look at the locally advanced population, and again, all of these patients were stratified by the group. So on Tuesdays, we have our multidisciplinary conference, and Drs. Lilimo, Fernandez, and myself, we all have clinic on the same day. We meet in the same conference room with 2 medical oncologists and 2 of the radiation oncologists, as well as a bunch of fellows and residents. And we go through every single new patient, and the patient gets assigned to what treatment algorithm we agree on for the group. And this really helps us enroll patients into clinical trials. But you can see here, so for the patients who were deemed locally advanced at the beginning of their diagnosis, again, we had about 80% who ended up going to the operating room. Some, again, were found to be truly locally advanced, where the vasculature still had a significant amount of tumor around it, or they had metastatic disease. And 88% ended up with an R0 resection. And so when you're looking at these 2 cohorts of patients, although we define them very differently at the beginning of their treatment, it may not make that much of a difference. And we may over time decide that actually it may not be so much the anatomic definition, but rather the biologic definition of who is truly borderline versus locally advanced. Because it's going to be those patients who respond or don't respond. Can we get them to the OR, or can we not get them to the OR? And so first I'll present our retrospective data, which hopefully will give you some insight. and then we'll move on to what we found for the clinical trials. And what we did was we compared patients who were deemed borderline or locally advanced and got FOLFIRINOX plus radiation to those patients who were considered upfront resectable, who we took immediately to the operating room. So we have our best performers, and then those patients who historically have had an overall survival of about 11 months to compare those two groups. And we stopped the data that I'm presenting is only up to January 2017, mainly to be able to give you a longer follow-up, to give you a better perspective rather than just having higher numbers. And this retrospective data does not include the about 100 patients that were randomized for the two clinical trials that I was just showing you. So some of the patients, two quick examples, and this is one of the first women we did, and this was a true affair of the heart, which is what Murray Brennan says you should never, ever do. So I always smile when I present her. But this was, a young woman, got FOLFIRINOX, got 50.4 gray of radiation, and you can see here there's still significant SMA involvement. And historically, we would have said, well, this patient's locally advanced and unresectable. But we said, well, if her CA19-9 goes down so much, she had no pain, and she had presented with a significant amount of pain, and she really looked fantastic. And she said, I need you to try. I need you to try. And so we tried and, approached the operation a little bit differently than we normally do. We came to the SMA from the left, right from the beginning, to take a bunch of biopsies, and all of that tissue was dead. So she ended up with an R0 resection with a T2N0 tumor and was alive for 4.5 years. This is another similar example where you see more venous involvement. Again, you end up with a good pathologic response. And the reason that we were probably more bullish and felt that ethically we could justify taking these patients to the operating room comes back from data that we have from Dr. Warshaw and Chris Willett, who was the head of radiation oncology for GI. And they had started a whole series of patients who had locally advanced disease that they surgically did not remove, and gave them somewhere between 10 and 15 gray of intraoperative radiation therapy. And so what you do is, I'll show you a picture here of my colleague, Carlos Fernandez and Ted Hong, and you can see that there's this cone that you bring directly down onto the tumor and you radiate. And you can see that although these numbers are not as good as we would always hope for, but for historical series, actually pretty impressive. And you can see there is a subset of patients who biologically we do not understand yet, who do respond, and by giving them this high-dose radiation actually can have a long-term survival because you have good local control. And so this is just some of the data that we have, and what we realized was, okay, when we gave the patients FOLFIRINOX, we were able to see smaller tumors, their CA19-9 went down. And I will tell you, if the CA19-9 is going up while we're giving FOLFIRINOX, we'll switch to gemabraxane to try to see some type of response. But radiologically, often the response does lag behind. What we did figure out also was that when we went to the OR, the operations were long, much longer than an upfront resectable Whipple. We lost a lot more blood and had to transfuse our patients much more often, which of course is very discouraging. And so, we worried that we were doing an exercise, a technical exercise that, although is very interesting and you learn a lot, are we really, adversely affecting the patient's outcome? And so when we looked back at the Clavien 3 or greater complications, we were relieved to see that they were not higher. Our readmission rate was not higher. Our length of stay was not higher. And most importantly, our postoperative mortality was not higher when we compared our upfront resectable, so our best actors, to those patients who were borderline or locally advanced. So we were really, truly relieved. And I think that some of the decrease in morbidity is because after these patients have gotten so much neoadjuvant therapy, the pancreas is hard and the duct is big. I mean, it's to the point we joke we can let the intern sew the anastomosis. And the pancreatic fistula rate, although no longer is 0 like it was in that first paper, it continues to be very low just because you have a nice hard pancreas to sew to. So when we went back to look at the pathologic results, we were also very encouraged. The tumors tended to be smaller, fewer patients. So when you compare, so upfront resectable, about 70% have positive nodal disease, and you come down to 36%. We had an 81% R0 resection rate with a margin that was greater than 1 millimeter, so the European definition. We had less lymphatic invasion, and we had less perineural invasion. So all of our pathologic factors, including the fact that about 11% of patients had a near complete response. Either we found no tumor or less than 1 millimeter of tumor. So this, of course, is incredibly encouraging. We say, okay, so the operations are longer, we lose a lot more blood, but we haven't overall hurt our patients. And the pathologic factors that we normally in resectable disease have looked at seem to have improved. But in the end, right, who cares about all of this? Because the patient really just wants to know, are you going to make me live longer? So we were very happy to see that we were able to shift the curve to the right, and that these patients that normally had a median survival of 11 to 12 months were really moving into a median survival that was looking more like 44 months, which was a lot. I mean, these are numbers that in pancreatic cancer we really haven't seen in the past. That although this looks so great and we look at these numbers and it makes us very excited, I do want to point out that when you look at the slope of this curve, the slope isn't that different from our upfront resectable patients, which clearly indicates we have a lot of work to do in understanding the biology of the disease and understanding how we can better treat our patients. And I just want to quickly put up this graph is because it goes back to this question of, upfront when we diagnose patients as borderline or locally advanced, is this really going to make a big difference in terms of their outcome? And is it really just, can we get the tumor out or we can't get the tumor out? And so the disease-free survival and overall survival, as you can see, are not statistically different for the patients who I just presented to you as a whole cohort when you parse them out as to what we designated them at the beginning of their treatment strategy. In terms of the intraoperative radiation therapy, about 35 to 40% of our patients do get intraoperative radiation therapy. So after the resection has occurred, we then have the radiation oncologist come to the OR and we give somewhere between 8 and 10 gray. It's 8 gray if we do any sort of venous reconstruction or have a lot of arterial dissection, and it ends up being more like 10 or 11 gray if we haven't done as much vascular work, just because of the risk of pseudoaneurysm for the arteries and a blowout or stenosis of the vein. And so the medical oncologist, brought up a good point, and I think that this is a question that we all have, is, okay, well, if the chemotherapy is so good, they get through radiation, and you're seeing this improvement, is the operation really worth it? I mean, you're putting them through a huge operation, and although the outcomes look pretty good, it's still a big operation, and it's a recovery of 3 months for the patients. And so we looked at the patients who were not resected when we took them to the operating room for whatever reason, either micrometastatic disease or truly locally advanced disease where the vessels which were involved still had a significant amount of tumor. And so this is one of those exercises where the research fellow comes into your office and brings a scroll of analyses that they've done for every single cutoff of every single preoperative parameter that we could possibly think of to try to figure out, can we preoperatively predict who is not going to go to the operating room? Now, this is a little bit biased because anybody who had their CA19-9 going up or clearly had growth of their local disease or metastatic disease on the scans, none of us took to the operating room, which I don't think many in the audience would do either. So it's really those people who look like they're having a response, but in the end don't have a good enough response. And so although this is not a prospective randomization, you can see that those patients who were not resected had a significant difference in their median survival. And so biologically, how to explain this, there are obviously a lot of theories, and one of them is the persister cells that are chemo and radiation resistant, and those are the ones who you're leaving behind, and if you're able to remove them, you may have an impact on the patient's survival. And so lastly, so this is all retrospective data. So last, I just want to show you the results that we published in JAMA Oncology from the borderline resectable trial. It is a phase 2, not a phase 3 trial. And the patients got 8 cycles of FOLFIRINOX, individualized SBRT. So they either got 5 times 5 gray of protons, or they got 10 days of photons. And then the primary endpoint that we put for the trial was an R0 resection rate. question always comes up of, is FOLFIRINOX really tolerable to patients? And I will say that our medical oncology colleagues around the world, I think, are really improving the way that they're able to manage the side effects, and they're able to give many more patients full dose FOLFIRINOX despite the fact that it's a fairly toxic regimen. So 81% of the patients were able to get all of the cycles, and only about 19% of patients had a grade 3 or greater toxicity from the chemotherapy. And you can see that then 97%, which I had already presented to you earlier, got an R0 resection after all of this treatment. But what is more exciting is that the 2-year disease-free survival was 55%, and the 2-year overall survival is 72%. So we have a median progression-free survival of 48.6 months, and we have not reached the median overall survival. So this is clearly an incredibly exciting time for pancreatic cancer, because we're really shifting the paradigm and the outcome and the outlook for these patients. And I think that this is going to evolve also to the upfront resectable population. I will tell you that the locally advanced trial is also closed, and we've submitted it to JCO, and so therefore I can't present the data, but I will tell you it looks very similar. So when it comes out, hopefully you will agree that it looks very similar. So just in summary, distinguishing between borderline and locally advanced disease, as we have in the past, may not be the best way to do it going forward as we better understand the biology of the disease. And as Scott presented, we have a lot of ongoing trials around the world that are going to help us answer a lot of questions and help us understand the disease. FOLFIRINOX is able to downstage about 2/3 of patients based on our borderline and locally advanced trials. Again, they are phase 2 trials, not phase 3 trials. The radiologic imaging, which we've relied on so heavily in the past, I really do think is unreliable at this point in time, and that patients they should get the benefit of the doubt, because a lot more tumors can come out than in the past, because the chemo and the radiation are so effective while not hurting patients. And the operations are longer, and the vascular dissection is a little bit more tedious. But we had a significant improvement in the pathologic factors that we follow, and a significant improvement in the overall survival, especially when we compare it to our best actors, which are our clearly resectable patients. But most of all, I think what we've learned is that multidisciplinary care for these patients really is the key to helping them live longer and have a better quality of life. And it is exciting because we are making a lot of progress, and it really is probably the most exciting time for pancreatic cancer. I want to thank my surgical colleagues, as well as our medical oncology colleagues, PATH, radiation oncology, radiology, and GI, because without them, we wouldn't be able to treat these patients. And without all of the research fellows, I wouldn't be able to do this presentation. So thank you very much.